Go.
Whenever you're ready.
Okay. Hi, everybody. My name is Goshgarian. I am an ER doctor and addiction medicine doctor here in Bishop. I've been in Bishop for about 7 or 8 years now. And I'm here to talk about opiate addiction. Maybe. Here we go. Okay. So just a brief overview. Today, we're going to talk about addiction as a brain disease. We're going to go into a little bit the opiate epidemic and the medication for addiction treatment program at the Rural Health Clinic, as well as give you a little bit of overdose education, because due to the fact that we're in an opiate epidemic, overdoses are happening at an unprecedented rate. And so I want you to be prepared in the event that you are a first responder to one. So I guess we have to start by defining what addiction is. It's a chronic and relapsing disease. And I want to focus in particular on the fact that it's a brain disorder that involves functional changes to brain circuitry, because in the past, historically, it's really been difficult for us to kind of understand and empathize for folks who struggle with addiction, because it's not something that we can see on the outside. So as a result, I'm going to go through a little bit of biochemistry, so stick with me. But first, I got to tell you what an opiate is. So an opiate is a substance that acts on opiate receptors in our brain. They are used medically to decrease the body's perception of pain. So they've been used for thousands and thousands of years, and originally were formulated from opium poppies. So there's data suggesting that they were used back in 3500 BC for recreation and medicinal purposes. And today they are formed both naturally and synthetically. So like I said, I have to talk a little bit about neurochemistry so that I can impress upon you the function of the opiate use disorder and how the disease of addiction works. So the brain is the supercomputer that runs our body, and it's made up of thousands and millions of tiny little gray cells that communicate to one another, just like the circuit in our actual computer. And they use neurotransmitters to signal to one another, which allow us to do everything that we do, from speaking and moving to feelings and emotions. Opiates act within our brain on our reward circuitry. So dopamine is our main reward and happiness chemical, and opiates act on that pathway. In the normal brain, there are endogenous or naturally made chemicals called endorphins that stimulate the dopamine response that cause us to feel happy. When we eat ice cream or chocolate cake, we get a little rush of dopamine that makes us feel good. That's what motivates us to continue eating chocolate cake and buying ice cream. Opiates sort of stimulate this system in a pathologic way. In the short term, they can be effective for reducing pain, but over the long term, they stimulate that dopamine reward system excessively. So it causes a state of euphoria, or a feeling of euphoria, that we feel like we're constantly chasing to get back. Over time, our brain is smart and adapts to that process ongoing. And so it decreases the amount of dopamine that we produce naturally with continued exposure to opiates. So as a result, when people have been on opiates for a long time, they often require higher doses of the medication or of the drug in order to achieve the same effect. And if they're on it for really long periods of time and then come off of it abruptly, they can have withdrawal symptoms that include some severe dysphoria, a really depressed mood, and lack of motivation that can be long lasting and even extremely detrimental for many years. So it can be a really difficult thing to treat. This is a very wordy slide, but I wanted to bring up that one of my mentors did a very neat study, but it's a little bit complicated, so stick with me. So what he did was he tried to understand how the opiates affect both our reward circuitry and our survival drive. So what he did, amazingly enough, he got people to volunteer for this study, but he managed to get people to agree to being put into a moderate to severe state of dehydration, depriving them of something that we would consider necessary for life in order to stimulate their survival instinct, water. And then he put them in a functional MRI machine. And a functional MRI machine gives us brain imagery that it happens in real time and allows us to see what chemical signaling is occurring in our brain. So he put these moderate to severely dehydrated people inside a functional MRI machine and started talking about water, rivers and lakes, and they were very, very thirsty, and put water on their lips and started tempting them with water. And the area of their brain that we would associate with craving something lit up about the relative size of a baseball. He did the same thing with people and put them into a state of moderate to severe starvation. So he said they weren't allowed to eat anything for a matter of days to weeks, and then put them in the same functional MRI machine and said, let's talk about your favorite food. Let's think about a warm, hot, greasy cheeseburger and French fries, maybe a piece of pizza, whatever it is. And that relative craving lit up the size of a basketball. And then he took some patients who were in recovery from opiate addiction, who had been sober from opiates for over a year, and he put them in that functional MRI machine and just mentioned Oxycontin, the name brand of one of those opiates. And that functional MRI lit up a relative craving the size of a baseball field. So these drugs really tap into our survival drive and dysregulate our system. But as a result, it gives me a lot of empathy for patients who are struggling with this. Because if a patient who hadn't had water in 2 or 3 days, was severely dehydrated, came up to me, and I had a glass of water in my hand, and I said, no, you can't have this. And they said, well, I'm going to take it from you. I wouldn't blame them, right? It's something that they need to survive. And that's happening 10 to 100 to 1,000 fold in patients who are struggling with opiate use disorder. So sorry about the biochemistry, but now we're going to talk about the opiate epidemic. So now we're in for current events. We're in the midst of an opiate epidemic right now, recently overshadowed by a global pandemic, but it hasn't changed the fact that we're still in the midst of a significant crisis. There are over 130 people who die each day in the United States alone from opiate overdoses. This probably began a little bit before the mid-90s, but the reason we're in the midst of this epidemic is likely because of these few perfect storm events that have led to people becoming addicted to opiates. The first thing that probably stimulated this was in 1996, Purdue Pharmaceuticals, a large pharmaceutical company, developed a drug called Oxycontin. It's a continuous release form of oxycodone, a potent opiate, and it was heavily marketed both to individual people as well as to providers. It was the pharmaceutical company really pushed in their advertising that it was safe and effective when used for pain control. So around the same time, the Joint Commission, which is the largest accreditation organization for the vast majority of hospitals in the United States, they decided that pain was a vital sign. So they put it up there with blood pressure and oxygen level and made it really a requirement that needed to be addressed in any medical setting. Also simultaneously, physician surveys like Press Ganey became really popular. And so patients were able to rate providers based on how well their pain was managed. So because there was all of these pushes, providers started increasing the prescription of opiates. Between 1997 and 2002, the number of prescriptions increased from 650,000 to over 6 million. in the US. And that's just one of a number of different opiates. However, in the early 2000s, we kind of recognized this trend in medicine, and we said there's increasing mortality rate amongst chronic opiate users. This is dangerous. This is scary. We need to do something about it. So the Drug Enforcement Agency started putting pressure on providers to reduce opiate prescribing. This meant that the number of opiate prescriptions went way down, and many people were abruptly cut off from prescriptions that they had been using for a long period of time. This meant that people were desperate to get relief from their both chronic pain as well as their opiate addiction that had potentially been iatrogenically caused or caused by the prescription in the first place. And because of that, there was a decrease, because of the reduced prescribing, there was a decreased supply in pain pills out in the general public. So unfortunately, they became very expensive, and people who felt like their survival instinct was triggered and felt that they really needed this medication turned, unfortunately, to heroin, which was a much cheaper alternative, although quite dangerous. So I consider the opiate epidemic to have had three phases. The first, we saw a rise in opiate overdoses when there was a rise in prescription. Those overdoses were predominantly related to prescription medications. Then there was a rise in heroin overdoses when the number of prescriptions went way down. And finally, we're in the current situation where we're seeing a huge and dramatic increase in overdose fatalities from synthetic opiates. So this is just another graph that demonstrates the significant increase in the heroin overdose deaths that really correlated with when we cut down on physician prescribing. Okay, so now we'll talk about fentanyl. Has anybody heard of fentanyl by chance? Some nods. So fentanyl is a synthetic opiate. Historically, opiates were derived from a poppy plant, like I showed you earlier. And so you had to grow a crop and then harvest the crop and distill the product down to make an opiate like morphine or heroin. But fentanyl is created fully synthetically. So it's created in a lab, which means it's fast and simple to produce. Scarily, it's highly potent. So it's much more powerful than morphine or heroin. And therefore it's extremely deadly. So in the top right corner, you can see the amount of a synthetic opiate called carfentanil that's necessary to cause a lethal overdose. It's the size of Abraham Lincoln's nose on a penny, or half a grain of salt is enough to cause a fatal overdose. Consequently, because of these highly potent and easily made and cheaply available substances really flooding our illicit drug market, we're seeing huge numbers of overdose fatalities. One of the things that I think is most scary is because these are so easy to produce, and because illicit drugs are not regulated in any way, shape, or form, they're being sold as everything under the sun, from pressed pills like a fake Percocet to being found and contaminating our methamphetamine supply, to people will say this is heroin when in fact it is fentanyl. And since it's 100 to 1,000 times more potent than any of those other things, it can be really deadly unintentionally, which is why we're seeing so many overdoses. Inyo County is not immune from the opioid epidemic. So this is a cool graph that divides up the entire country by county. And Inyo County is so big that you can see it pretty easily right on there. And so we are above average as far as number of overdoses per person in the county. But we're not as significant as some of the counties in the Rust Belt over there in Ohio, West Virginia, and Pennsylvania. They were hit particularly hard by the opioid epidemic, but we're still above average. So something that we're definitely want to address and focus on here. I also want to mention that this data is notoriously difficult to find and absolutely underreported. As an ER doctor, there have definitely been times when I've been asked to sign death certificates where this data comes from, but it's really hard for me to ever write opiate overdose caused the fatality. And the reason for that is because I usually try to stick to facts that I know. Things like, this was a cardiac arrest that caused the fatality. This was a respiratory arrest that caused the fatality, because I'm never truly 100% aware that it was an opiate overdose that caused the cardiac arrest. So it's really underreported data. This is a photo of our medication for addiction treatment program team. I'm proud of my team. We're small and growing, but a group of dedicated NIHD employees, and we have partnered with community partners, including law enforcement like Bishop PD. So the MAT program, MAT stands for Medication for Addiction Treatment. So it started in 2018 in the emergency department. Randomly, we got a call in the emergency department. I'm an ER doctor by training, and we got a call from a very bigwig, head honcho, emergency department person in the state of California to our little ER in Bishop. And she said, "Are you guys treating opiate use disorder in the emergency department?" And I said, "No, I didn't know that was a thing." And she kind of mentioned, "Well, it's really gratifying work. I would really recommend that you do some research into this. Here's a grant opportunity that I think you would be a great fit for." And that really sparked this whole program. So it was born in the emergency department. And when I think about that, it makes a lot of sense for the emergency department to play an active role in addiction management, because it is the only 24/7 access to care point in the community. And so we want to meet patients where they are when they're ready to get treatment and to get help. And that might be in the middle of the night, or it might be on a weekend. And so the emergency department having that open door policy and being able to initiate things has been really, really helpful. The program follow through all is embedded within the rural health clinic. And that's my team that I showed you on the last photo, as well as, again, community partners that help us continue to reach patients throughout all phases of their addiction. We use evidence-based practices to support patients and help them find wellness. I'm a doctor, so we use FDA-approved medications to treat opiate use disorder. I'm not going to go deep into those right now, but they are extremely effective and easily available. We recognize that people aren't their disease process, so we try to maintain a patient-centered approach to care that's really patient-centered and patient-driven. We also utilize, because addiction is a disease that affects every element of our lives, we use a biopsychosocial model. So we focus on behavioral health, we focus on recovery support, and we really want to make sure that we provide trauma-informed care. Trauma-informed means that we recognize that we are the sum of things that have happened to us, and therefore we try not to stigmatize patients based on what has happened, and acknowledge that we need to meet them where they are. So one of our goals as an MAT program is reducing stigma. As healthcare providers, we are definitely at times guilty of perpetuating stigma. And so one of my jobs is to help try to make sure that we provide a compassionate and safe place for patients to find treatment. Stigma is a social construct where when people who do things that are outside of the social norm are perceived as less desirable and punished or judged for what they have done. Unfortunately, that causes people to feel as if they don't deserve care and contributes to extreme isolation, which is another hallmark of addiction, and something that needs to be broken down in order for us to help patients get help, find treatment. So we have a big subset of our program that focuses on harm reduction. Harm reduction means that we try to reduce the negative consequences of substance use. We recognize that there's no linear path in addiction, that there's a relapsing portion of this disease. And so when patients are struggling in active addiction, we don't want them to feel like they can't access care. And we really want to focus on reducing negative consequences of substance use. So we want to reduce stigma, treat patients with dignity and respect, and create a space where people, even in active addiction, can actively engage in care without being afraid, without fear of being judged. We want to meet those patients wherever they are in their journey on their road to recovery. And we don't want to leave them in that space. We want to support them to making changes. So now I want to do a little bit of overdose education. Like I mentioned before, the opioid overdose rate in this country is extremely high. The vast majority of those overdoses happen in a home environment. And so one of our goals is to get Narcan, which is the reversal agent, into the community so that everybody can join my team in helping save lives and reducing stigma and preventing overdose fatalities. So now you get to join the team too. So what we've been doing is handing out opioid overdose rescue kits. And there's a bunch of them here. I didn't bring one up. For you guys to take home. And if anybody at home is watching and would like one, I'll be happy to get one to you. So these kits contain Narcan. And Narcan is a nasal spray that reverses an opioid overdose. So this is the Lazarus drug. This brings people back from the dead. And it's designed and marketed for people with no medical training at all to use, because we want you to be there in the event that you have the opportunity to save a life, to have the tools available to you to do it. Overdose situations are one of those very, very scary things that even with all my education as an emergency room doctor, I wouldn't be able to do anything about if I didn't have this. So I want you to be able to have this to do something if you need it. So this is your Narcan training. And in the event that you are a first responder to an opiate overdose, I want you to know what that looks like. It's really scary, but what you may find is someone who is unconscious. So the first thing to do is try to wake that person up. If they're just sleeping and you wake them up, no harm done. But if they don't wake up, when you shake them, call their name, if they're not responding, they may have shallow breathing or no breathing. They may have blue face or fingernails or lips. First thing to do is call 911. You can definitely save this person's life, but you're going to need help doing it. So call 911. This is a life-threatening emergency, no matter what the cause is. If someone is unconscious and unresponsive, 911 should be on their way. But in this case, I want you to be prepared to administer naloxone. So it's a nasal spray, and it looks just like that in the picture. You hold it kind of like they have shown with your finger on the plunger. You put it into the nostril and you plunge the medication. So if you ever have allergies, like Flonase is kind of similarly administered. And after you administer the Narcan, place the patient in a recovery position, which means put them on their side, and wait for 911 to arrive. So it's really, really simple. We have had numerous overdose reversals in the community done by lay people, just like you guys, as well as by law enforcement and other bystanders. And so we're trying our best to get this to everybody and get this education out there, because it's a real and it's a dangerous condition. So that's it. So now you're ready to save lives and you have the tools that you need. Any questions for me?
Is there anything happening in the community with any kind of recovery program for opioid?
Absolutely. So the question is about recovery programs. And I didn't go really deeply into the recovery programs, but one of our team members is our recovery navigator. So her job is to help with patients who are finding recovery, whether that be that they need higher level of care, meaning they need to go to an inpatient treatment program for a while. She helps them get into those type of programs. Additionally, she helps with recovery support groups that are long lasting. So in patients who have found early or long-term recovery, they meet to discuss what works for them, what helps into the recovery programs. But one of our team members is our recovery navigator.
Sorry about that, everybody.
No worries, I'm loud. So yeah, we do try to support patients from a holistic standpoint in finding recovery, because we know that it's really hard to maintain that over long periods of time. So we want people to feel really well supported in that.
And is the funding gotten any better for that kind of stuff?
The funding has actually been really quite good. Now we are so fortunate that, because I told you this really big wig person called us right away early on in our initiation of treatment for addiction. We've been really fortunate to have amazing coaches and have grant opportunities that are really incredible. So we've applied for and received a lot of grant funding to support both the program and our community. And it's been really amazing to see the kind of community support we have had surrounding this, because that's one of the things, both the community support and the executive level support and board support of Northern Inyo have been extremely influential in us securing a great deal of funding and building this program. But we're doing it not alone, but with the help of coaches who are really incredibly influential in the field of addiction medicine. We were involved in a study by Stanford to figure out if what we're doing here is reproducible for other rural communities nationwide. And so we've really been lucky to, because I answered that phone call early on, to have gotten in with the right people who are really influential in addiction medicine and addiction treatment. And they've paid attention to what we're doing here and trying to replicate that in other places, while simultaneously guiding us as we continue to grow and expand and improve our program.
So you're doing detoxification locally?
So that's a great question. We are doing medical detoxification locally, but nothing that requires inpatient. So there are certain medications and drugs that when patients come off of, they are risky. Withdrawal is a life-threatening situation of a lot of drugs. And so there are certain medications or certain times where patients may want to go to a detox center to go through withdrawal. They often have medical monitoring that is kind of overnight and hospitalization type of monitoring. We don't have that here, but our recovery navigator often helps us arrange that when we feel that that's necessary for patients. So we do outpatient detox here, which means that they come into the rural health clinic on a frequent basis while they're going through withdrawal. And we give medications to help ease some of the withdrawal symptoms that makes the process safer and more effective.
I don't want to hog all the questions.
No, that's all right.
Go ahead.
No. So my personal experience with Narcan was my husband had fentanyl for cancer pain.
Yeah.
And my insurance didn't pay for the fentanyl.
Really?
Yeah.
That's terrible.
I had to pay a lot.
Because it's expensive.
Yeah. Yeah. So, you guys with the grant funding are able to give it out.
Yeah.
And can a parent come to you if their child is using drugs and get that from you for free?
Absolutely. So Narcan is something that I want everybody to have, whether or not you know anybody who uses opiates, although I would say they're really, really common, because chronic cancer pain and all kinds of chronic pain are very, very, very common, unfortunately, very common. And so accidental overdoses that come from, people not necessarily knowing that they're on opiates, or from a child finding a prescription and accidentally taking a pill. These are definitely one pill can kill type of medications for young children. So we want this to be available everywhere, because accidental overdoses are unfortunately quite common, because it is a dangerous class of medicines. So we want Narcan to be everywhere. So absolutely, we have lots and lots of boxes of Narcan available, lots of these overdose reversal kits that we want to give out. So anybody who knows anybody or who just wants one can come and get one from us.
Okay.
Yeah. And as far as adolescent and child treatment goes, that's something that we're working on. Right now, we don't have a good program in place for adolescent treatment. Although in the state of California, children over the age of 16 are allowed to seek out drug treatment. without the consent of a parent. We haven't gotten that into our program quite yet, but it's certainly on our horizon. We recently applied for a large national grant in conjunction with some of these other larger entities, like I think UC Davis was involved in it. We applied for a large grant in order to help us build a program for adolescents. We are one of the rural communities that they asked to partner with them so that we could again be a guinea pig, if you will, for developing a program that could be replicatable to other rural communities nationwide. So,
is there any kind of public education for adults to, say, secure their narcotics like they would their firearms?
Yeah, that brings up an excellent point. We should have that. I don't know of anything specifically. What I know is that one of our harm reduction strategies is to give out medication lock boxes and lock bags. And every time now, I would say that one of the challenges I have is by the time I interact with patients, the cat's out of the bag a little bit. As an addiction provider, by the time I interact with them, they already know that their medications that they were on were addictive and potentially abused and usually have street value. But it's something that we're working on making available is medication lock boxes and lock bags so that people can be aware that these medications are both dangerous and need to be taken very seriously and locked up so that they're not stolen or don't put anybody else in danger. So those are other things that we have that we're trying to get into widespread use.
We have a question in the chat. It was, what was fentanyl originally made from?
So fentanyl was originally made, and it's still widely used medicinally. So I use fentanyl in the emergency department. It's a great medication because it works really well for pain, acute and chronic, but it has very limited blood pressure effect. So one of my big challenges in a big motor vehicle collision in a person who got in a bad car accident and may have multiple fractures or be bleeding from somewhere is that their blood pressure can go down. And morphine or some of the other medications that we use to control pain in an acute emergency setting can cause blood pressure to dip a little bit. Fentanyl doesn't necessarily have that effect as much. It's very fast and short acting, and it doesn't cause that lower blood pressure. So it's a great medication to use in an acute trauma setting. However, it's highly, highly reinforcing, very, very potent. And when it is an illicit use, it's quite dangerous because it's not regulated or monitored in the same way that it is when I'm giving it from the hospital.
They also asked, does Narcan expire?
Narcan does expire. And so you do have to pay attention to the expiration date on the Narcan. However, there is the FDA approved an extension on the expiration date for Narcan, oddly enough. I think that was done because the military did a bunch of studies on all types of drugs that demonstrated that they were good well past their expiration dates. So the military uses expired meds. That doesn't seem great, but they take a lot of expired drugs and use them for active military participants and VA people. But based on that, the FDA approved an extension on the Narcan expiration dates. And so any of our Narcan kits that we're giving out near the expiration date, we try to put a sticker on that says it says the expiration date is X, but the real expiration date is Y, which is usually, I think it's 18 months after. So if it does expire again, we have more, and we're happy to re-up anybody who needs new supply.
I have a comment. One problem has always been where, say, like a patient's going to have surgery and the doctor gives them a script for something post-op, maybe 30 tablets or whatever. And I know for a fact that a lot of times people will say, oh, no, I have plenty, I don't need any. And it just, they give them the prescription, they go out, they fill it even though they don't need it, it sits in a cabinet. And so then people come and they steal it, which is something I think that a lot of people don't realize happens a lot.
Yes.
But a lot of physicians, it seems like they don't watch who is getting it and, or maybe pharmacies are monitoring that or?
Yep, you're right. So we do have a lot of monitoring that is in place. So we have to check prescription drug monitoring systems. Now, it's not really for what you're talking about. Those are more for people who are doctor shopping or going to multiple physicians in an attempt to get prescriptions to divert them or sell them. So our prescription monitoring software is really to look to flag that so that we are not allowing medications to be diverted for illicit use. But what you're talking about is absolutely correct. We definitely see people who don't utilize the full prescription that they were given after a surgery in particular. And so those meds can sit in the medicine cabinet in perpetuity if allowed. They are a target. They can be stolen. They can be dangerous for any bystander who goes in there thinking they're getting Tylenol or something like that. And so we're trying to encourage a drug take back program is what we call that. So we also have medication envelopes available, and they're available at Dwayne's and the police department as well. That are an envelope that you can put your medication into. They ask for nothing that is injectable or anything that could be like that. We have other ways to dispose of that stuff. But we have medication take back envelopes that go to a clearinghouse where they get disposed of properly and safely. So we're trying to encourage anybody who has any old leftover medications lying around to get rid of them because they are dangerous. And if you have another surgery, we'll get you more medicine. That's not no need to keep that stuff. It's dangerous. And so we want to be able to free up your medicine cabinet.
Has there been any legal or laws affecting physician prescribing that they can, limiting the amount they can prescribe?
There are definitely laws that limit the amount and frequency of prescriptions. I'm not well versed on those because I tend to be on the other end of things where I'm not doing the active prescribing, I'm doing the treatment. But there are definitely laws and rules that have come into place right around that early 2000 timeframe where physicians started getting a lot of pressure to reduce prescribing. So those rules and restrictions were put in place for the safety of everybody, but unfortunately had this adverse effect of contributing to a lot of people seeking relief from other sources. So turning to illicit drugs to get the sense of relief that they would have gotten from their prescription medications. So we saw at that time a lot of pill mills got shut down. Pill mill is a term that was used for a lot of pain management doctors who are just writing prescriptions for large numbers of narcotics that were well above what would be considered safe or rational, often cash pay. And before those drug monitoring programs were put into place that would demonstrate if somebody had been receiving pills from every doctor every doctor in the state in an effort to sell those for cash. So we definitely saw that in the early 2000s, and there were definitely laws and rules put in place to kind of minimize that. And a lot of those physicians got, lost their licenses and don't practice.
A lot of our local people go up to Nevada for treatment, surgery. It's very odd. If you have surgery up there, you have to get your narcotics up there.
Yeah.
Because you can't fill.
You can't fill, so the narcotic prescriptions don't cross state lines.
In all states.
In all states. So that is one of the things that is one of the measures that they put into place to protect patients from obtaining too many prescriptions. The drug monitoring programs that we look at are state specific. So I look at the California drug monitoring program. I also have access to the Nevada drug monitoring program. But I look at the California drug monitoring program, and as a result, any prescription that I prescribe has to be filled in California. Any narcotic prescription has to be filled in California. The same thing is true with Nevada providers. So you're right. In our situation, it's kind of unique because we're a border community. And so often we have patients who get care in Nevada. And I've definitely had that in the past where a patient has gotten a surgery up in Nevada. Maybe it was outpatient or they left the hospital and made it all the way back to Bishop and found out at that point that they were unable to fill their medications. So that's an unfortunate side effect. most good primary care providers or even good pharmacists can work together to, contact the prescribing doctor to make sure that medication wasn't filled at the other pharmacies, check the Nevada drug monitoring program, and find a way to get the patient the medication without them having to drive back. But it's a complex and difficult process that involves a lot of moving parts. So definitely, if you get surgery in Nevada, try to pick up your meds before you come home.
We had another online question. What are some telltale signs of opioid addiction?
That's a great question. And that's a really difficult one to answer, because I would say that, the telltale signs of any addiction are compulsive use and use despite adverse consequences being the hallmarks of the disease process itself. So in the event that somebody is continuing to use opiates after they have themselves have recognized the need to cut down or to stop using based on adverse consequences or input from other family members and friends, and yet they're unable to stop. Now, I need to differentiate that specifically because opiate addiction is something that is really often confused with opiate tolerance. So there are people who have chronic cancer pain or chronic conditions that are painful, like sickle cell disease, where they may be on opiates for a long period of time, but not necessarily have an opiate addiction. They may develop some of the same symptoms of tolerance and withdrawal if they abruptly stop using them, but they don't necessarily have addiction if they aren't using despite adverse consequences of the medication. If they're not using larger amounts in longer durations than they themselves intended to, if they're not having interpersonal conflict in family drama because of their use pattern, if they're not getting in trouble with the law because of their substance use. So it really is kind of a fine line, because there are a lot of people who are on long-term narcotics for very good reason. But there's also this population that when the use becomes a pathologic pattern, when it starts to have adverse consequences. So I would say that it's hard to really say that you could pick out an opiate user from afar, because that's not necessarily true. It wouldn't be easy to do.
I don't think we have any more questions in the chat. Anyone else have any final questions?
Well, Sarah's did a really good job. All right, well, thanks for coming, everybody.
Thank you.
Thank you, Dr.
Yeah, thank you very much, Doctor.
Oh, I do want